Good. So my brief was to talk about common paediatric ENT conditions and problems. I've got a little bit of knowledge about osteopathy, but I have to say not a great deal. I know that quite a few of my patients do see, I'm sure I've seen many of you in the room here. So I've made a few sort of assumptions in what I'll be talking about. I'm guessing that you don't particularly want to know in any great detail about operations that I do, and perhaps less about the medicines, and are more interested in things that might be of practical use when you're seeing patients. So I've chosen a number of conditions that are mainly paediatric conditions. Some of them also occur in adults as well. So I'll be talking about those conditions, and also spending a little bit of time on warning signals, red flag symptoms that you might find helpful to be aware of, and may help alert you to patients that you should perhaps be referred on to secondary care. I'll also just be spending a little bit of time talking about examination of the ear and the nose, so you know how we do that in the hospital, that you may or may not want to do that yourself. So a bit about ear examination. I'll be talking about glue ear. Acute otitis media is a very, very common problem in children. 90% of children have ear infections, 50% of them have recurrent infections. Rheumatologia or earache and the other causes of that. A little bit about dizziness and vertigo. Then a couple of nose problems, acute sinusitis and nasal obstruction, and then just a brief word on sore throats and tonsillitis. If I have to talk about anything else, please do interrupt, ask any questions that you've got whilst I'm going along. So first of all, examination of the ear. Certainly, if you speak to any junior doctor and you ask them to examine an ear, the first thing I'll do is grab an otoscope and I'll go and really try and look at the eardrum straight away, forgetting there are actually other parts of the ear. So think about the external part of the ear canal, and then the eardrum. And then the ear also does something, so it hears and is also responsible for a sense of balance. The nerve that supplies all the muscles of the face also runs through the middle ear and can be affected with ear conditions as well. So some patients can have problems with facial weakness. So when you look at the external ear, have a quick look behind. People often don't remember operations they've had on their ear. It may have been a long time ago, may have been in childhood. You can often see scars behind their ear. They're often really quite well hidden. The ear canal runs in a bend. The outer 2/3 are made of cartilage. The inner third is made of bone. And that's important when you're looking in the ear, because you need to straighten that out to have a good look at it. So when you're examining the ear, you need to pull the ear upwards, outwards and backwards, and that'll straighten out that bend. And you can often actually, just with your phone, you can actually see the eardrum if you do that. The other thing to note is that it's only the outer third of the ear canal, the hair-bearing skin there, that actually produces wax. This is one of the reasons why we tell people not to use cotton buds. You end up pushing it back into this part of the ear where it shouldn't be. And it serves a useful purpose. It's acidic, it creates an environment that prohibits the growth of bacteria, presents infections, and also helps clear skin debris, shed skin cells from the ear canal. So this is just to show the ear is very, very well set up. So if you look at, this is a normal eardrum, there's a little drop of ink that's been put on the middle of the eardrum. If you watch it over the next day or two, you'll see that it gradually moves out to the edge of the ear canal and then up the ear canal. So the ears will clean themselves, they don't need cotton buds, which generally cause more trouble than good. So here's a normal eardrum, so a slightly cropped image. You've got your incus here. You can actually look through the eardrum and see quite a lot through it. With regards to exam, I'm not sure if you will be examining ears, but you can get very cheap otoscopes now. You can also get digital otoscopes, so if you're uncomfortable looking at the ears, you can take pictures to send to the patient's GP if you wish. So you've got the long process of the incus there. That little dark area there is where the round window sits. That separates the middle ear from the balance organ. You can't quite see it there. There's dark shadow there where the eustachian tube runs from the ear to the back of the nose. So here's an example of what you might think is just wax on the eardrum, but it really shouldn't be there. It could have been pushed there by a cotton bud. You always need to be a little bit concerned about wax in the inner part of the ear where it shouldn't be. And if you take that off, you often find there's these big holes underneath where caused by cholesteatoma, which is essentially skin that's growing in the ear, and it can gradually erode through bone. It's a very slow process, happens over several years, but can cause very serious problems, which I'll come to a little later on. Is also here, and you can do very simple tests in your clinic rooms to assess how the ear is working. These are called free field voice tests, and they're actually surprisingly reliable tests of hearing if you do them properly. So that involves just shielding the ear so the patient can't lip read you, and then rubbing with the other finger on the other ear, so you're just testing one ear. And then you start at 80 centimetres, so full arm's length, with a whispered voice, and then go to a whispered voice at 20 centimetres, and then a conversational voice at 80 centimetres. And that'll give you some pretty reliable thresholds. Now, one person's whisper, you say whisper, one person's maybe very loud and another not. This whisper is generally defined as being after you've fully exhaled, and then you're whispering as quietly as you can. Generally, if people do that, you can be pretty confident the patient's got normal hearing. So those are the types of hearing you can assess. So whispered voice at 20 centimetres, they've got a mild hearing loss. Conversational voice at 80 centimetres, a moderate hearing loss. Sort of glue ear, a very common condition. It's essentially a normal part of childhood. Pretty much every child will have glue ear at some point in their childhood. Clearly, it can cause problems with hearing loss. That's the most common way it will present, and following that was some speech delay. But there are also some other, perhaps less expected, issues that you might find, and these don't always come with hearing loss or speech delay, so they can happen in isolation. So education behavioural problems, the sort of the naughty boy at school, and it's really because he's not catching what the teachers are saying. Problems with balance often occurs in people with children with recurrent ear infections. And this one here might sound rather counterintuitive, but sensitivity to sound. So children have what's called hyperacusis and be very sensitive to loud noises. So to make a diagnosis of that, it's obviously the appearance of the eardrum. If you look at that eardrum there, you can really sort of feel this thick mucus on the other side of it, which is what glue ear is. So there's your normal eardrum, and that's the eardrum with glue ear behind it. So examination and then a hearing test to show that they've got hearing loss, and we'll also do pressure tests as well. So as I mentioned, it's essentially a normal part of childhood, so the vast majority of cases it will settle by itself without any treatment. So in the main, we don't intervene with problems with glue ear. Usually occurs following an upper respiratory tract infection, mild cold, something like that. And if you look at a child under the age of 5, after a month, 50% of them will still have glue ear, mucus behind the eardrum, and 10% of them will still have glue ear after 3 months. So in my practice, obviously, we're guided by the NICE guidelines, which recognise that effect. We won't do anything at all, really, or in the vast majority of cases for 3 months, because most often it will settle. There aren't any medicines that are known to be of any benefit to help resolve glue ear. There's studies going on at the moment looking at oral steroids, but as things stand, there are no medical treatments for glue ear. There are a number of things that you can do. The only treatment which has been found to have some benefit is autoinflation, which is essentially getting the child to pop their ears frequently, a few times a day, and there's a balloon that you can buy called an auto-vent balloon that the child puts in their nose and then blows up, and it's a controlled way of them ventilating their ear. And so if the glue ear persists for 3 months with a documented hearing loss, and in that situation we say, well, we don't have to do anything still, unless there are particular problems with speech delay or education problems. But you can put grommets in, I'll show you a picture of that in a moment, or use hearing aids. We don't commonly use hearing aids, but that's certainly an option. So that's a grommet. That's just a small plastic tube with a hole in it that we put in and allows the ears to drain themselves. They stay in for about 9 to 12 months before they fall out. And usually that's all that's required, but about 1 in 5 children will require further sets of grommets. So on to acute otitis media. So this is, again, I mean, it'll be familiar to most of you. Child present with a sort of painful ear. If they're under the age of 18 months, they may just be sort of pulling their ear, be fretful, they have a temperature, and really seem quite obviously out of sorts. And this is what you'll see with, if you look at their eardrum. It's sort of red, angry, and bulging, and occasionally that will burst through and give rise to problems with discharge. So again, there's a normal eardrum. There's the eardrum with acute otitis media. In the main, as I've mentioned earlier, it's a very, very common childhood infection, but it is important to be aware that occasionally can give rise to some pretty serious complications. And it's worth just spending a moment looking at the anatomy of the middle ear. So with an acute otitis media, you've got the infection in that space there, in the middle ear. And that infection can spread anywhere in that region and give rise to problems. In about 3% of children, they have a little dehiscence, a gap in the bones of their skull, and that gives rise to the potential for them to develop problems with meningitis. Following ear infections, it can spread on the inside and give rise to problems with a sensory neural deafness, come through the ear canal, occasionally it can come track down and present with abscesses in the neck. This is a cross-sectional view, and this is the mastoid bone behind. Again, occasionally it can spread back and cause it's called a mastoiditis, or an infection behind the ear. So these are the kind of potential complications that you can run into in children with ear infections. Mastoiditis, meningitis I've mentioned. Facial nerve palsy, I mentioned that earlier. The facial nerve runs there in the middle ear. 5% of people, there is no bony covering. Most people have a bony covering, which provides it with some protection, but as I say, 1 in 20 people, there are gaps in that. Dizziness from affecting the balance organ here. I've mentioned sensory neural hearing loss. And these are abscesses that can appear in the neck. Retinal syndrome is pretty unusual, but it can cause problems with the cranial nerves, one of the cranial nerves from spreading inwards. This is a child with mastoiditis, and you can see here, if you look from the front, their ears protruding there, and they have these sort of hot, swollen abscesses behind their ear, and that's something that really, any of these complications, they really do need to be seen in hospital to be treated, and the treatment for this is surgical, so we'll drain that, we need to drain that abscess and put grommets in the ears. But as I mentioned, most of the time we don't need to do anything again with these ear infections. They'll usually settle by themselves. So delayed antibiotic group, this side here, it actually forms the majority of patients. And if you actually just keep an eye on them for 3 days, if they've got no warning signs, it'll just get better and they don't need antibiotics. So children with relatively mild symptoms over the age of 2, which constitutes the majority, generally just need to keep an eye on it, but be aware of those warning signs. So as I mentioned earlier, 50% of children will have recurrent ear infections. This is actually something we really don't have very good treatments for. You can just treat them in the way that, with or without antibiotics, in the way that I've mentioned earlier. Prophylactic antibiotics really don't work very well. Some people will give children antibiotics to take every day for 4 to 6 months. And you might have thought that might be quite helpful, but actually it's only 1 in 7 children will actually get any benefit from that form of treatment. And that's not to say it eliminates infections, it just reduces the frequency of infections. So if they've got having more than 6 episodes a year, then that's the time we'll think about putting some grommets in the ear and possibly taking their adenoids out. The adenoids are lymphoid tissue that sits at the back of the nose where the ears drain. It's worth knowing about risk factors for acute otitis media. Sometimes there's something you can do in this regard. Breastfeeding is helpful. The maternal antibodies in the breast milk do provide protection to children. And this is one of the reasons why you will often see ear infections start a couple of months after breastfeeding has stopped, so the child no longer has that protection and has to develop responses from their own immune system. But almost invariably, these problems with recurrent infections will settle by the ages of 2.5 or 3 once their immune system has matured. Childcare, children get to childcare, they're just exposed to more bugs and they will have more infections as well. Anything you can do about that. Bottle propping is when the child is held flat and just held with the bottle propped vertically down, and that gives rise to the milk will reflux back into the ears and give rise to problems and infections. Smoking is terrible. Smoking environments are predisposed to ear infections, and just make sure they've been vaccinated, because again that helps provide some cover. I just thought it'd be worth spending a brief moment on talking about other causes of earache, because I imagine people with neck problems are probably fairly common in your practice. And earache is a very common manifestation of neck problems. But don't forget all of the other potential causes of earache. So the ear shares the nerve supply with very many other parts of the head and neck region via these other cranial nerves here. And anybody who has an unexplained earache for 3 weeks or more should be treated as having cancer until proven otherwise. So those are patients that we should be seeing in hospital. Chances are that there isn't, but they certainly do need to be reviewed. Just be particularly wary of the heavy smokers and heavy drinkers who are at greater risk. So if you look at the number of the potential causes for earache, let's say neck, degenerative disease, arthritis in the neck, very common cause of earache. You can also be caused by problems with dental disease, temporomandibular joint, jaw joint, arthritis, any problems within the nose and sinuses, and also throat problems as well. So when for example, these are all caused by referred pain. So an example of that is children have their tonsils taken out, they always have terrible earache after about 5 days. Because of this mechanism. It's on to vertigo. It's probably more of an adult problem, but is also very common relatively common in children. I'll speak more about that in a moment. What is vertigo? People often think of it as being a fear of heights or being dizzy, but it's very important to define what it is. And it's the hallucination of movement. So it isn't just spinning round, it is feeling as if you're moving when you're actually not. And it's a very, very primitive sense. So it predates our senses of sight and hearing in terms of our evolutionary development. So any problems with our balance give rise to, in the vast majority of cases, with associated problems of muzziness, anxiety, and even memory loss. So this is just to highlight the relationship between our vestibular system and our hearing. So you've got the cochlea here. The cochlea here, the organ of hearing on the right, and it's in the same fluid-filled compartment as the vestibular system. So problems with balance and vertigo commonly associated with problems with hearing. So as mentioned before, vertigo is the hallucination of movement. So when patients come in and say they're dizzy, really need to establish what they mean by dizzy. Is it because everything's spinning around, or because they feel as if they're walking on a boat, or they're on a boat, or walking on cotton wool? Those are symptoms of vertigo. But people also say they're dizzy when they feel as if they're about to faint, or if they're just feeling generally unsteady. You want to find out what it is that tends to trigger these episodes, and a really important point is the first ever episode of vertigo, and that will often give you the diagnosis, what happened on that occasion. Were they confined to bed for 3 days with terrible, terrible dizziness? Was it just for a couple of hours, or was it short-lived for a minute? So that's the also includes the second question. People who are confined to bed with rotatory vertigo for 3-4 days generally have had a problem with what's commonly called a labyrinthitis or a vestibular neuronitis, and that will generally get better by itself. But it is something that I work very closely with physiotherapists with to help them recuperate from that. And again, I can imagine that osteopathy may well be a very helpful intervention in people who are recovering from problems with the vestibular neuronitis. So associated symptoms that might have with it, so as I mentioned, problems with deafness, you need to require to have any noises in the ear, any discharge from the ear or pressure sensations. Problems with dizziness and balance, again, includes examination of the ear. I won't spend too much time on these other tests, other than to mention the Dix-Hallpike test. Does anyone here do Dix-Hallpike tests or Epley's manoeuvres? So I mean, it can be a very satisfying test. This is for people who have benign paroxysm or positional vertigo. This is when the crystals come loose in the balance organ. The Dix-Hallpike test can help confirm that, and an Epley's manoeuvre treat it. I'm very happy to speak to anyone about the details about how one does that later, if you're interested. So just a brief overview of the other cause of it. There are non-vestibular, so problems that aren't to do with the balance organ. So always think about cardiovascular causes. So these are the patients who think they're about to faint, or they do actually faint and lose consciousness. There are other sort of systemic problems that can. Musculoskeletal symptoms, and again, I would imagine that many of the patients you see may have these problems with degenerative arthritic changes, degenerative change in their cervical spine, and the kind of symptoms that they present with is often a very a sense of disorientation, as if they're in a glass box, as if they're not quite there. People with musculoskeletal issues find it very hard to define their symptoms. From 70% comes from your sense of vision, 15% from your proprioception, your joint position receptors, and 15% from your vestibular system. So if you've got problems in any one of those symptoms, it can give rise to problems with imbalance. And vertigo, if you've got problems in two, then you really do run into more serious problems. So I've mentioned BPPV. Meniere's disease, that is, again, episodic vertigo, usually lasts for several hours, and that is really a clinical diagnosis. It's a combination of intermittent episodes of vertigo with unilateral tinnitus, so constant ringing noise in one ear, and fluctuating deafness, and that's a sensory neural deafness. And they often have problems with oral pressure sensation in their ear as well. And that commonly presents with migraine, and this is actually, if you look at the pediatric population who have problems with vertigo, the vast majority are due to pediatric migraine, and that can present in a similar fashion to Meniere's disease. And yes, obviously these are much less common causes of vertigo, but there are central causes that can give rise to vertigo. So the treatment depends on what the cause of it is, but in the majority of cases, it is actually not treated. It's not treated with medicines or surgery. It is to do with lifestyle interventions. So vestibular rehabilitation exercises to train the brain to habituate to the sensation of vertigo, and that's extremely effective in many of the causes of vertigo. Making sure that their vision is optimized as much as possible, and occasionally we'll give medicines. Just be a little one word about vestibular sedatives such as prochlorperazine, which can be very, very useful if people are acutely vertiginous, that actually have actual vertigo. But if people take it regularly, then it can impede that central compensation. So it can actually slow down the recovery. So if patients come in and they're taking Bucostem or Stemetel 3 times a day, then they need to stop taking that. So not only does it slow their recovery, but also they run the risk of side effects, principally Parkinsonism, along with many other potential side effects. Fine, so examination of the nose. Again, usually with an otoscope, just first, most important thing actually, even if you haven't got any equipment, is just to lift up the tip of the nose to have a look and see what's happening with the septum. You can use a tongue depressor or any shiny object just to hold underneath the nose to assess how the airway is. Have a look in the mouth, because sometimes you have problems with the nose that can extend into the mouth. And examination of the neck as well, so just feel the neck, check there are no lumps or bumps there. Sinusitis is, it's worth dwelling on how we define sinusitis, which is, as I've put up here. So it's a sudden onset. You've got 2 or more symptoms, one of which should be either nasal blockage or discharge, plus or minus facial pain, plus or minus reduced smell. We'll commonly see people who have problems. Yes, I've got terrible, terrible problems with sinus pain. And if you look at the population of people who have sinus pain without any other nasal symptoms of blockage or discharge or reduced sense of smell, 90% of them have no problems with their sinuses. Commonest cause of this is migraine. So look for, when people come in with problems with their sinuses, look for those nasal symptoms. I won't dwell too long on this, but again, just to draw attention to the fact that actually most cases it's mild, most of the cases we don't treat with antibiotics. It's just either simple nasal washes in the nose, paracetamol, and Nurofen. And again, when to refer, as with ear problems, sinus problems can spread to nearby organs, and these are the kind of situations which you should think about referring. So swelling around the eye, because sinus infection is spreading into the eye actually protruding, anybody who's got double vision or reduced vision, and then these signs here of potential intracranial complications of sinusitis. So anyone with severe pain or headache at the back of the head, stiffness of the neck, need to be referred. I think I'm running a little bit behind time. So just with regards to nasal obstruction, it's helpful to think about structural problems and medical problems which give rise to inflammation of the lining of the nose. If you look at people with medical problems of the nose, I think I've got that on the next slide, about a quarter of them will be non-allergic, but they will present with symptoms of allergy, such as sneezing and an itchy nose. 43% of them will have allergic rhinitis, and 34% will have a mixture of allergic and non-allergic problems. I mention that because people commonly think of allergies, but actually there are all these other multiple causes that can give rise to allergic type symptoms. And again, if you can reduce your exposure to any of these, then you can help these kind of nasal symptoms. Allergic rhinitis is a very common problem. Nearly a third of the population has it. Allergen avoidance measures, i.e. avoiding what you're allergic to, is the most important thing. We will generally treat them with antihistamine, steroid sprays, and very rarely surgery. Septal deviation. So if you, let's say, you lift up the nose and have a look, you can often see people have bends in the septum. They're very common. About 80% of people will have some form of bend in the middle partition of the nose. By and large, it doesn't cause any problems, but it can cause problems if you have an allergic or non-allergic rhinitis on top of that. Most of the time, we don't treat them with surgery, usually either allergen avoidance or lifestyle changes, and occasionally steroid sprays in the nose can help. I won't spend too long on this. I think just a brief word on tonsillitis and sore throat. Again, very, very common childhood condition. We actually, in the majority of cases, don't do anything about this because the natural history of tonsillitis is that will settle of its own accord. The difficulty is knowing when that's going to happen, if it's going to be if people have had their last episode of tonsillitis, or whether it's going to go on for the next 15 years. So we do have criteria about when we think about taking out tonsils. If you've had tonsillitis for a year, then we like people to have had 7 episodes of a proper disabling sore throat. If they've had it for 2 years, then 5 episodes a year. If it's for more than 3 years, then 3 episodes a year. So it has to be a pretty serious problem for you to merit taking out someone's tonsils. Good, so I think that's all I had to say. So please let me know if you have any questions.
How effective is apis maneuver, do you think?
Works very well in about 80% of cases.
Just one time, or is it just like a series of the maneuvers over a period of time? Or?
Usually just once. A proportion of them will recur, probably about 15% of people will have recurrent problems. And in that situation, you actually teach people to do the apis maneuver themselves in that minority of patients.
Do they vomit all over you when you do these things? Because a few times I've done this, I've had to sort of duck.
I've not had that yet.
Yeah, I've had it a few times, which is pretty horrible.
But what I would say is that probably 1 in 10, 1 in 15 patients, it will cause problems with severe vertigo. And they may, I always warn people, or check they haven't driven to the clinic, or if they have, that they don't mind if they have to wait around for an hour or so afterwards whilst the dizziness settles.
Would you put grommets in a 3-year-old that's been diagnosed in NHS with gluing and has speech problems in certain letters that he says?
Grommets, there's always shades of grey. The NICE guidance is actually based on evidence in children from 3.5 upwards. So children under the age of 3, clinical judgment will come in, but if they've got problems with speech delay...
it's not delay, it's that certain words are clear, so his parents understand him, but if you heard him speak, you'd think that, yeah, it's just certain things he will say, yeah, certain letters he can't say.
I would probably be more guided by the hearing test, and if the child had problems with confirmed hearing loss for more than 3 months, then think about it. But children always catch up. So there's no problem if you leave it for another 3 months or 6 months' time. And if it doesn't settle, then putting grommets in at that point is absolutely fine. If it does settle, the children always catch up. So there's no evidence that it causes any long-term problems with development. So you can be pretty flexible in the main with the management of gluing.
Is there any good treatment for tinnitus?
First of all, check there aren't any potential medicines or causes for the tinnitus, principally medicines, so certain types of antibiotics, certain types of antihypertensives, some diuretics can cause aspirin, can cause problems with tinnitus, so check they're not taking those medicines. There aren't, as things stand, any good medical or surgical treatments for tinnitus. People have tried severing the nerve of hearing in people who've had debilitating tinnitus and still doesn't go away. So the mainstay of treatment is cognitive behavioural therapy, what's called tinnitus retraining therapy, lifestyle changes, which can be extremely effective, but many people there aren't sort of quick fixes for it, so to speak.
Any more questions at all? Well, I'd like to say thank you very much.